Welcome everybody to today's CMR Journal Club. And today, more and more often, topic is around artificial intelligence. And so it is also today that model-based analysis is something we have to look at because not only because it's the general hype, but that would not be a good reason, but because it's just all the opportunities that are associated with that. And we have two really, really interesting papers today. One is coming, and we'll start with that one, is coming from the Beth Israel Deaconess Medical Center and Harvard Medical School. And it's called Needle-Free Myocardial Blood Flow and Reserve Quantification using AI-enhanced coronary sinus flow MR imaging with exercise cardiovascular magnetic resonance. And I'm particularly pleased to welcome Alexander Schulz, who is he's about to finish his time in Boston, originally from Germany, and he will present the paper. So Alexander, thank you very much, and take it from here.
Thank you very much, Matthias, and thanks for having me today. As you can see, there are two other people, one in front of me and one in the end, which is Manuel and Reza. Both would have a PhD as a title behind their names. I have an MD behind my name. So if you want to roast someone on decoders and encoders today, feel free to do so. I'm the right candidate because I probably won't be able to answer all the details, but I'll do my very best to explain the brilliant technique Manuel has developed behind this whole research work. So let's just dive into it. So the rationale for this study is that we all know that our conventional perfusion imaging, especially quantitative perfusion, is feasible, enhances our imaging, is a great upcoming technique. However, it requires contrast agents and pharmacological stress, which is not feasible in all the patients and also not needed. I mean, with conventional perfusion images, the biggest gain is, of course, that we can identify regional perfusion defects, which are particularly relevant for coronary artery disease. However, many diseases have diffuse perfusion abnormalities, especially metabolically sick patients. Microvascular disease and diffuse or global diffusion abnormalities become more and more relevant. And those can be captured with coronary sinus flow. So the coronary sinus essentially captures all the blood flow return after it past the myocardium. So we are not imaging on the delivery side of the coronaries, but rather on the return side. However, what goes in needs to come out, so it should be the same. So a reduced coronary sinus flow is kind of equivalent to a reduced myocardial blood flow on the coronary side. We know that it is an established technique, CS flow. However, exercise CMR is an upcoming and emerging technique which allows for stressor-free imaging. So we don't need any pharmacological agents, but it imposes additional challenges through motion artifacts, and we need a higher temporal spatial resolution, especially with those little structures. And this is why we set out in this study to test the AI-enhanced CS flow technique with a spatial resolution of 1.1 times 1.1 millimeters squared and at a temporal resolution of 27 milliseconds. Okay, so now let's jump into the design of the technique, and I'll just fast forward to this image. It looks complex at first, but let us go through it. And as I said, I'm not the expert on all the encoders and decoders, but I will do my very best to explain what we did over here. So we acquired flow images over here and in a special fashion. So we reduced the resolution in the phase encoding direction to only 30% of the original case baselines, which allows an acceleration of about 3.3 times, right? At a graph rate of 2, so allowing approximately a 6.6 times acceleration. Those acquired case baselines, so only 30% of the lines, were zero padded and put in the center and produced a low resolutional image, which was enhanced by the AI block. I just call it AI block. However, the resulting image, we kept the original center case baselines where the most important information on the spatial resolution are encoded. So we replaced the reconstructed case space center with the original acquired case space center. So this is on the spatial side because it was acquired in a low resolution on the spatial end of images. However, it was also acquired on a lower resolution on the temporal end. So we know in phase contrast imaging, we need a velocity compensated and a velocity encoded image for every frame to see the phase offset, right? However, what Manuel did, he acquired the images in a non-interleaved fashion. So he acquired one cardiac phase, one image completely as a compensated image, and the next one completely as a velocity encoded image, which essentially lowers the temporal resolution, so makes it worse, but then interpolated by two velocity. So he interpolated then the images in between the two acquired images. So essentially doubling the temporal resolution again and restoring it. So this non-interleaved acquisition scheme allows for a higher acquisition rate with lower acquired temporal resolution, which then can be again re-enhanced. This is the idea behind it. So we have basically acquired low temporal resolution, acquired low spatial resolution, which are then again enhanced to restore it to the so set 1.1 millimeters squared spatial resolution at 27 milliseconds. The combined acceleration in the end was about 13 times. So we want to test the sequence, and therefore we recruited adult patients with known stable coronary artery disease without hemodynamically significant stenosis. And we put them on an exercise protocol, which is standardized at our institution. And the resting acquisitions of the CS flow, we acquired them twice to assess scan-rescan repeatability. And for the exercise images, we acquired the quantitative perfusion images first in all subjects, followed immediately by the CS flow images. It is important to know over here we perform out-of-bore exercise. So the patient is exercised outside the bore, then quickly transferred into the scanner within 15 seconds, and then the acquisition starts. So just to keep this in mind. What we found in the end is, so we were able to have 12 of 13 of the recruited patients available to assess scan-rescan repeatability. And in 11 patients, we had paired data of rest and stress CS flow, as well as myocardial blood flow from regular quantitative perfusion images. And what you can see that reproducibility of CS flow was very good with scan-rescan repeatability of with an ICC of 0.97 and inter-observer variability of 0.97 as well for the CS flow and for the myocardial perfusion and for the CFR. So sorry, for the CS-derived CFR or MPR, however you want to call it, also 0.97. And both measurements were highly correlated. You can see a better agreement for the resting images, which makes sense because they have, of course, better resolution than for the stress images, which is partially explainable because they were acquired after each other. So CS flow was always acquired a little later than the quantitative perfusion image. However, the myocardial perfusion reserve in both types of perfusion acquisitions was even better correlated than the individual values of myocardial blood flow at rest and post-exercise. In the end, I want to highlight a couple limitations. So the first one is the delay, of course, may underestimate the peak stress flow. And I don't want to claim that we are capturing maximum myocardial perfusion with this. This is a different approach and should more be considered as a, let's say, proof of concept paper. Of course, we have out of plane movement of the vessel, which sometimes makes acquisition and evaluation harder in patients. And this was a breath hold acquisition with a breath hold of 11 seconds. So this might not be feasible in older or sicker patients. And one last thing, which is a limitation, of course, that we didn't compare our AI enhanced CS flow sequence with the with the regular flow sequence in this paper. So just by the data we have available over here, we cannot prove that AI is, or the AI enhancement is completely necessary, but we assume that the increased temporal and spatial resolution improves accuracy of flow measurement and vessel border delineation. So in the end, we conclude that it's possible to quantify CS flow post-exercise with excellent repeatability and good agreement with conventional perfusion images, and allows for a needle-free, contrast and pharmacological stress-free CMR. Thank you very much.
Thank you very much for the very clear presentation of your work. And you mentioned already the questions I had, so you basically preemptively pretty much answered them. In case for others, as usual, leave your questions in the chat or raise your hand, so then we can take, of course, take any questions. But the one you said, I think that the time lag between the end of the exercise and the actual studies, that is an issue, because usually within 2-3 minutes after end of exercise, blood flow comes back to normal. So there is not much time left in between. So I think in the paper you said it took about 15 seconds to get the patient back into the scanner, or the participant into the scanner, and then assuming setting up the sequence, or it's probably repaired, but starting the sequence, and then it's probably then 1.5 minutes until perfusion is done, and then the sinus flow measurement. So it's right at the so my question is, as long as this is standardized, I think it's okay. The sensitivity may be not 100%, but were there big differences between participants? So did it take much longer in some people, or was it really a very smooth routine workflow that was always the same?
So I think that's one of the most important notes you can probably make on post-exercise imaging.
Yeah.
And we have to argue a lot about it. However, so there's a high routine over here. I think we do like 3 to 4, sometimes 5 exercise CMR scans a week. So the stuff is well trained. It's a very efficient process. However, you need that training to get efficient, right? So the 15 seconds, I think this is even long. So this is on the upper end. I mean, the acquisition time of the quantitative perfusion images afterwards essentially depends on the heart rate of the patient, of course. So you would, if you would just be interested in a CS flow, you would, of course, prioritize it before the quantitative perfusion. However, this was as part of a different study. So that's why we put myocardial blood flow or conventional quantitative perfusion first in this study. But yeah, there is not much variation across subjects.
Okay.
We also take note of that. But yeah, I wouldn't consider this as a problem.
Second very quick question, because then we have to move on to the next, is the impact of AI. You mentioned that you did not directly compare non-AI versus, so super resolution versus regular resolution, but I bet you have done something before that paper that you looked at it. can you quickly comment on that? Because I think measuring blood flow in the coronary sinus makes a lot of sense. And my personal experience with that is a few years ago, but it was actually much better than I had expected. It's between 6 and 10 millimeters usually. And if you have pixels of, let's say, 1.5 millimeters, that gives you at least way more pixels than nuclear medicine has across the myocardium. So it's not that bad. And if this super resolution would be consistent and actually accurately reflecting what's happening in that area, that would be very, very good. So can you disclose what was the impact of AI on accuracy, or the difference between the two?
I don't have it for CS flow available because we haven't done a comparison. But Manuel, so the first author of this paper who developed the technique, tested it in aortic flow to prove that we are the temporal super resolution in particular, to prove that we are improving our rate of capturing actual peak flow.
The peak,
and
exactly.
and he was able to show that we can actually improve let's say the peak flow rate. The spatial resolution, I mean, we use this AI enhancement with this interpolator for many different sequences, for LGE, for cine images, for real-time scenes, and it works. It's very accurate, the spatial interpolation at least. But I don't have it available for CS flow. I think this is one of the major limitations at the moment of this paper.
No, thank you very much. This is in many ways is a great great study to learn from and to guide future research. So thank you very much, Alexander. So we'll move on to the next paper. It's called Development and Validation of a Non-Invasive Model of Mixed Venous Oxygen Saturation in Heart Failure. So it's a model-based assessment of oxygen saturation, which is one of the important parameters that we need in assessing various aspects of cardiovascular physiology. So this is very interesting, and it's from Newcastle in the UK, but it's a collaboration also with Leeds and with Norwich, and presenter will be Peter Svoboda, who is also the senior author of the paper. So Peter, if you could share your screen and walk us through your study.
Okay. I'm sharing my screen now. Can you see that okay? Is that too big? Shall I zoom out a bit?
It's not yet, at least for me, it's not yet
let
shared.
me... oh, wait, share.
Yeah, now it's...
I didn't press the share button.
Yeah. No, that's great. Looks good to me.
Great.
Yeah,
great. So let me tell you. So this is a long story, and I'll try and keep it brief. So probably 2018, I started off this heart failure registry where we started scanning heart failure patients with quantitative perfusion. And as part of the study protocol, we included dark blood, late GAD, and T2 maps. And I was saying to Dave Broadbent, our physicist, why can't I look at the late GAD in the right ventricle of these patients with heart failure? The dark blood T2 maps, they just don't work because the blood is so bright. And he said, oh, that's because they've got low oxygen saturation in the right ventricle. They've clearly got a very deoxygenated ventricle, and therefore... And so we went back and we looked at it, and I thought, this is pretty interesting. This is something we could make use of in heart failure, because actually it's an incredibly important physiological parameter in heart failure. You know, the Fick equation is based on your exercise capacity, is based on two things: your cardiac output and your mixed venous saturation. We're incredibly good at measuring cardiac output. We've heard some fantastic data already about how you can measure cardiac output without contrast and without with physiological stress. But we're not very good at measuring mixed venous saturation. Patients still have to have a right heart. There really isn't any alternative to have a right heart other than having a right heart cath still to measure mixed venous saturation. So I went away and I read the paper from Ohio, if you remember it, from JCMR many years ago, where they took pigs and they worked out the mixed venous saturation in the right ventricle by altering the tau 180 between the refocusing pulses in the T2 map, and they were able to very, very accurately measure right ventricle oxygenation. And I thought, this is great. We should try this in humans. But of course, in humans, it's very difficult to implement that clinically because there's a non-linear fit in that model. You need changing the refocusing pulse separation isn't available in a standard T2 map on the scanner, so you need a whip to do that. You also need to think about other things like hematocrit and T1, which are going to influence this value. So lots and lots of data needs to go into this very accurate model. So we thought, well, what if you just take the ratio of the right ventricle over the left ventricle? Because a lot of these things are going to cancel each other out. You know, hematocrit, T1, they're all going to cancel each other out, with the assumption, of course, that the left ventricle has 100% saturation, which is a very, very big assumption for this model. So in Newcastle is our local transplant centre, and we really don't do a lot of right heart cath in normal cardiology anymore, and in the UK anyway. And so it's mainly done the transplant centres. And so we had a lot of these patients who were getting right heart cath and CMR within 1 or 2 days of each other. Some of these patients really very, very sick, which was really good because it gave us a load of really low mixed venous saturations, much lower than you would get in normal everyday clinical patients. But also then, to enrich this a bit, we got some Pankaj and Norwich is doing a HFpEF study, and so we wanted some patients with HFpEF who've got low venous saturation as well. So this wasn't all just we didn't just want to be recruiting patients with very, very advanced heart failure. Sorry, my lights just turned off in my room, but it's okay, you can still see me. So we started off with these 30 patients who have got right heart cath and CMR within 2 days of each other, and I'll show you their characteristics here. So they're pretty young, 40 years old. Average ejection fraction was okay, actually. It was like, what did I get? Oh, no, not okay. It was 22%. So still most of them were from Newcastle. So really poor ventricles. And their right ventricle over left ventricle was 100, and the right ventricle T2 was 104, and left ventricle 178. And we experimented with lots of different ways you can do this, doing it in the mid ventricle, doing it in the base, doing 4-chamber. We found that doing short axis and in the base gave us the smallest field of view and the most reproducible values. And so that's what we did for all of our patients going forward. We did have all these different things, and in the in the derivation cohort, we tried all these different parameters and things. And then so we have now got this model, which you can see roughly there. We started off with just this correlation between between measured saturation and the ratio, and already that correlation was very, very good. If I show you down here, you can see the correlation is already 0.8, which is pretty remarkable considering they're up to 2 days apart, and some very high numbers of mixed venous saturation, and some of these patients are very, very sick pre-transplant patients. And so we've got a really wide range, and overall the correlation is pretty remarkable. So we started with that model, and if any of you know Pankaj, he likes messing around with the statistics, and we messed around a lot with it. We tried T1, we tried different fitting non-linear models, we tried adding constants, we tried adding hematocrit. Really, you can't, the improvements in this were so small, they just detracted from the clinical usability. And so this is what we stuck with and we agreed on. And then we wanted to test it in this big validation cohort. And so we have this big validation cohort in Leeds, this big heart failure registry that we've done, where everyone's had stress perfusion CMR for presumed non-ischemic heart failure. And we had 519 patients in the study who had T2 maps, and I think it was around 3 years of follow-up. And we analysed the scans in exactly the same way in the basal slice with two regions of interest, and we worked out that ISVO2. We called it ISVO2. SVO2 is what they call it a right heart cath for mixed venous saturation. It's the marker of oxygenation in the right ventricle, but it should be pretty constant. Oxygenation should be pretty constant in the pulmonary artery, right ventricle, right atrium. So that's called SVO2. And so we called it ISVO2 for imaging-derived SVO2. Just to make it a little bit clearer that we were talking about the imaging-derived. And we followed them up for 3 years for this endpoint of death or heart failure hospitalization. We felt this is a really strong endpoint because there is not too much room for interpretation or it's a fairly robust endpoint for using these sorts of clinical studies. And the way we split it up is into these three. Now, when you're doing these prognostic studies, you can often argue with reviewers a lot about the best way to slice up a cohort. And bearing in mind that we wanted this to be a really clinical study, we went with the values that were recommended by the transplant center. And the transplant center told us that they would, if someone has an ISVO2 of less than 50, if someone has a mixed venous saturation of less than 50 on their right heart cath, then they are worried about that patient. And they're worried that that patient needs urgent escalation of therapies. So 50 was the red line, if you like, an ISVO2 of less than 50. And above 50 to 60 is sort of intermediate, and then above 60 they would consider just to be completely normal. So that's how we picked these values rather than tertile. So the groups aren't exactly the same size. The above 60 group is a bit higher because our patients had heart failure, so we've got fewer patients with completely normal. But fortunately, the reviewers agreed or bought into that. And you can see there's really clear separation of the death line in the patients with the ISVO2 less than 50. So this is really strongly prognostic. And the really important thing about this is those lines keep separating. So having, we're picking up patients who they're struggling already at baseline, their supply and demand, because that's what mixed venous saturation is measuring. It's measuring the match between supply and demand of oxygen to the peripheral tissues. And the supply and demand just is not matching, and you keep getting increased risk of mortality throughout. And same for heart failure hospitalization. And then so the primary endpoint over here is really, really clear separation of those three lines. And for all the imaging biomarkers that I've worked with for a while, this is certainly one of the ones that has the most impressive association with mortality. You can see in our Cox regression here in table 3, heart failure hospitalization, for every 10% your ISVO2 drops, your chance of being hospitalized for heart failure doubles. And then we had a pre-specified idea that we wanted to correct for age, sex, and ejection fraction, because I was particularly worried that the derivation cohort had a lot of patients who were really sick with really low ejection fraction. I wanted to make sure that we weren't biasing our validation study. So we corrected for age, sex, and ejection fraction, and still everything was still strongly predictive. And then, as is the way, the reviewers asked us to correct for lots of other things, and we did that in a separate model. And even after correcting for everything that was prognostic in our cohort of 500 plus patients, ISVO2 was still strongly predictive of heart failure hospitalization and the composite endpoint, although the association with death goes after you add in so many covariates. So I'm going to just go to the limitations, which I think is a really important part. Really, the biggest one is that we assume left ventricle saturation to be 100% here. So this is not, I don't think this can be used in patients with less than 100% saturation, so i.e. those with respiratory disease, maybe pulmonary hypertension, maybe patients with congenital heart disease where they're cyanotic at rest. I think this whole thing relies on the left ventricle saturation being assumed to be 100%. we didn't have any patients with really severe anemia. I didn't tell you, but there was a correlation in our derivation cohort between hematocrit and hemoglobin and the ISVO2. And given that, given that there is an association between T2 star and hematocrit, I think this is another important limitation that we haven't really tested this in patients who are severely anemic. Yeah, we in both studies, the number of patients with HEF was low, and we put that as a limitation. Although that's methodologically, there's no reason why patients with HEF should be any different. And so hopefully, I think I'm more or less on time for my 10 minutes. I hope that's okay, and I'm happy to answer any questions and discuss.
Thank you so much, Peter, for this really brilliant presentation. I really love the kind of the colorful context that you provided on the history of the paper. This is what you do not see when you look at the journal, and this is makes us also, I think, sympathize with the work. We're all, as scientists, we're all struggling with problems, and it's sometimes good if you feel, hey, well, there are others sitting in a similar boat, and we all have to row. So really fantastic. I have a few questions that to me at least, are very important. One is, do you think, or how did you address the problem of, or was it a problem at all, of the surface coil intensity correction? So the gradient of the surface coil, because that may be a question for some people.
I don't think that was not an issue that we came across. I think right at the beginning we did some phantom work with Dave as well, but which we haven't included in here. I will say from my experience is that the artifact at 3T was more, and it was certainly harder to do this at 3T than it was at 1.5T. You can draw very big regions of interest, and it's pretty easy. But at 3T we did have more artifact.
Okay, and then you mentioned this as a limitation, the saturation in the left ventricle. Have you thought about how we could address that? Would it make sense to have? I know in the old days we had sometimes little phantoms that we stuck to the chest with a predictable oxygenation. Or did you have any ideas what you could do, or would it help to have a peripheral saturation? Because the scanners may have a device to track that.
Yeah, I think that would be the starting point, wouldn't it? To start with another validation, maybe in patients with pulmonary hypertension, because in patients with pulmonary hypertension have low saturation and a lot of right heart catheters, and then I suspect you'd have to include. You might have to include more variables in that model. I think it would become more complicated. I think it would be more complicated than just a simple correction. But actually, there's so many patients that with bog standard left heart failure that this could be used on. I think that as a starting point, I think this is something that there's more than enough clinical uses for this right now.
And then sometimes it doesn't make sense to wait until things are perfect, because even the imperfect solution already has so much benefit. And to me, this smells a little bit like that. So that's why my last question is, have you thought about how you could help translate that into actual clinical applications? So any help for people who want to do that, so that it's actually used?
I think, for me, this is I think this is one of those things that it needs validation in multiple different diseases. I think there are diseases where the mixed venous saturation is potentially really, really powerful and can help prognosticate, because I'm sure we all agree that left ejection fraction is perhaps not the most useful tool in many, many conditions. And, I'm thinking maybe in early myocarditis, it might be really powerful, because a lot of these patients with early myocarditis, we don't know who's going to go on to develop heart failure. We know that they've got a very big injury, and some of them do very well and some of them do very badly, and it's very difficult to predict at the outset. Obviously, HFpEF is something I'm interested in. I think that would be one. The other, maybe valvular heart disease, but we need collaborators to who either have data sets with T2 mapping in all of these, but
certainly
sharing is what it's all about.
Yeah. Okay, while we have to move on, of course, my co-host Nicole is always totally entitled to raise her hand and then also get online. So, Nicole.
Oh, perfect. Yeah, so I want to say congratulations. This work is very, very interesting, and I think it's a really cool application of mapping and to do something totally different. But I have a question, and I'm curious what you and others think about this. I'm always very reluctant to look at signals from the blood pool, because if we're collecting data over multiple heartbeats, I'm assuming that whatever blood is in the heart is different from heartbeat to heartbeat. And this is, I think, why looking at the relationship between, these values and ejection fraction is a really, interesting question, and interesting that you didn't see any, real relationship there that would be useful to include. But what do we think about this? Like whenever I'm thinking T1 mapping and I have whatever my blood pool value, and even if we're using it to kind of make some corrections for things like extracellular volume fraction, I'm always weirded out by the fact that we're looking at signal levels from the blood pool at all because of the fact that we're collecting them over these multiple heartbeats. Do you have any thoughts about how we are collecting a reliable signal, even though some of the blood has been impacted by prior portions of the pulse sequence and some of it is coming in fresh every single time?
If anyone else has opinions,
I know it's a mean question because it's something that we
pretend
is not there. I feel like we may have somebody who wants to comment though.
We draw a lot of circles on T1 maps in the blood pool every day, and we don't have any. Nobody's ever had a problem with it. I suspect it may be the imperfect solution.
I mean, I think it's interesting.
David is also, as a co-author, is also. Do you want to say something to that?
Yeah, if I can chip in there. I think one of the key differences with the T2 method to the T1 is that everything's happening in a single shot. The T2 prep is done immediately before the acquisition shot. So yes, there's some blood motion. But it's not like a Molly where we have an inversion pulse and then we're requiring
over multiple heartbeats.
Multiple heartbeats.
I mean, are you worried about residual signal, though, that's arising from the blood that has seen a T2 prep pulse that is still there then when the next, shot comes in for the next heartbeat? Because then it is fresh blood, but there is still some blood that has been impacted by the prior portion of the pulse sequence.
It's a fair point. Yes, there could be a bit if there was residual blood, or I guess if the blood had moved from the right side to the left side and had experienced previous pulses, that could be a biasing effect on the left side. I think the key thing, as Peter was saying, is this is a pragmatic approach. We accept.
No, totally. And that's why, I love a pragmatic approach that works well. And so I think, I find it fascinating that, if I feel like if I would think too much about it, I'd be like, well, that's not going to give me something reliable because of exactly that problem. But the fact that it does give you something reliable and it is very simple is actually really awesome. So I'm not criticizing it.
So a shortcoming from Reza, as a senior author of the paper, you raised your hand, but we'll have to wrap up soon, Reza.
Sorry, I missed the other paper I was scanning, but I just want to comment on Nicole's question. Yes, it, in my experience, makes a huge difference, and particularly with the T2 mapping sequence that we have that is designed and optimized for myocardial T2, is totally biased for blood pool because you just don't have the resolution to be able to estimate that high T2 values. So that's the biggest issue that we face when we calculate this. These are not really designed for high T2 values. So you get these biased results, especially when you're looking at the left versus right. And it really depends also how much time do we have. There are multiple different implementation of this on vendors. Sometimes they use time per second, like 3 seconds or 4 seconds between T2 prep acquisition. Sometimes they use beats. So it really depends on what sequence, but that's really an effect on the measurement you have.
So I think this is a super fascinating discussion, and it's been prompted by this awesome paper. So again, I want to congratulate you because this work is really great, and I feel like it's a lot of food for thought. So thank you.
Okay, thank you very much, everybody, for the great presentations and the fantastic discussion. So both authors, really, thank you so much. Nicole, do you want to comment on the next journal club?
No, because I think it's you.
Oh,
because it's it's all good. We swapped weeks because it's the 4th of July that week, but we'll figure it out.
So I'm totally unprepared to announce that, but I promise you, within the next 2 weeks, we'll announce the next papers for the July Journal Club. thank you, everybody, and enjoy the summer. Be well, and see you next time. Bye-bye.